Well, hello, everyone. Thank you so much for joining us today at our webinar, Innovative Strategies to Enhance Cross-Sector Collaboration for Improving Health Equity and Outcomes. I am Jeremy Racine, Senior Director for Government Healthcare here at Innovacer, and I will be your moderator for today's session. So over the next hour, we're going to dive into how collaboration among government agencies, community organizations, payers, providers, can drive real, impactful results for Medicaid beneficiaries. We'll explore innovative cross-collaborative efforts, including examples of operational policy and program efforts, discussions about how data, analytics, and AI are an essential part of the connective fabric that holds our collaborative ecosystem together. We'll hear perspectives on what the future holds, and also offer an opportunity for you, the audience, to interact with our panelists and expand the conversation. Now, this isn't just a presentation. It's a collaborative conversation about how we can all work together to enhance Medicaid for all. Now, before we begin, I just want to cover a few logistical items. So our session flow will go as is. About 40 minutes we'll spend talking with our esteemed panelists, after which we'll reserve around 10 minutes for questions and answers. So for the Q&A portion, we encourage folks to use the Q&A feature that's inside of the webinar platform, and we'll take a look at those and bring them up during the Q&A session. And finally, we'll wrap things up with a brief summary. Additionally, just as a note, you'll see two polls that will be live for about a minute apiece throughout the webinar today. And those are live participation, so we encourage everybody to please participate. And lastly, we'll also have an opportunity to provide feedback at the end of the webinar. And the feedback is essential to the success of future webinars, so we certainly encourage everybody to participate and provide feedback. So without further ado, we are going to kick things off here. That's all right. Can get my mouse to work. I'm very excited here to be joined by this esteemed group of panelists today. We're just going to do a quick round of introductions here. So we'll start with Jason McGill. So Jason is the Assistant Director, the Washington State Healthcare Authority. He's Director of the Medicaid Program Division there. We're also joined by Jay Ludlam, who's the Deputy Secretary of North Carolina Medicaid. Also with Karen Shields joining us, who's a CEO at K Shields Health Tech Consulting and the former Deputy Director of the Center for Medicaid and Children's Health Insurance Program at CMS, as well as Abner Mason, Chief Strategy and Transformation Officer at Ground Game Health. So let's go ahead and dive right in. So how are innovative cross-sector collaboration approaches reshaping Medicaid outcomes, and what challenges remain? I'm going to start with you, Jason. You've spent a great deal of time both on the program and policy side of the house, having previously served under two governors and now a senior leader with the Medicaid program. The Medicaid program, which I will remind folks, is often talked about for its strategic approaches to collaboration and innovation. Some of the collaborative efforts include your recent waiver efforts focusing on reentry support, in addition to enhancing Washington's Accountable Communities of Health initiative, and your current efforts around health-related social needs. Jason, can you share with us some of your experiences in regards to collaboration in the state of Washington?
Yes, thank you, Jeremy, and welcome, everyone. I appreciate you joining and look forward to the conversation today. Gosh, Jeremy, I can go back thinking about Medicaid expansion, first of all, and thinking the important opportunity that presented to transform the healthcare system and to really ensure coverage and access. And thinking from their behavioral health integration, so integrating physical and behavioral health and really whole person healthcare, and moving to whole person equitable healthcare. And as many challenges remain, a lot has occurred in really a decade of time, not to mention a global pandemic in the middle of all that. But just more recently, as you touched on, Jeremy, I'm thinking about our, as you mentioned, our waiver activities, our 1115, this is the Medicaid waiver that provides states some demonstration authority outside of traditional Medicaid rules. And the two that really come to mind that are transformative really are our reentry services for our criminal justice population. And we are doing an incredible amount of work in that regard. And the second bit there is our health-related social needs services, and building off of in Washington, what we use are accountable communities of health or regional collaboratives to work with not only traditional healthcare sector, but say our community-based organizations and other organizations that we now need even more to support our health-related social need programs. But talk about reentry in a little bit more detail, is I know Jay's going to get to what great work in North Carolina happening about particularly HRSN work. But reentry is our priority now from our new waiver in Washington, and really standing that up, looking to July 25 for our first phase. This involves a pretty significant amount of work and implementation challenges. I call it our 1,000-point plan, and I'm not exaggerating. Our Excel sheet, project sheet, shows about 1,000 different lines of project needs here. And it is significant. It's significant in terms of engaging a population that not only of providers, of jail administrators, of sheriff and police chiefs, of local county council, and really building out partnerships in new ways, in addition to people with lived experience, and working and trying to develop a council of people with lived experience to help us with that. And trying to work with law enforcement and others who healthcare is not their field. And so building out a project that involves a number of new entity and new people to Medicaid is incredibly challenging, and great opportunities ahead, though, to help reduce recidivism, to help people get medication for opioid use disorder, and cures for hepatitis C. And so the promise is great, not to just mention simple transition services from jail to the community. And so building linkages from our jail providers to our community providers to help serve the people in need. Let me stop there, Jeremy. A lot more to talk about, but would love to hear from others.
Thanks so much, Jason, and certainly excited to see how things progress there, and the incredible work that you all are doing, and continue to be a leader in the space. Jay, you got a good baton handoff, I think, from Jason from across the other side of the U.S. But
Right.
Just to kind of tee up things for you, you spent a considerable amount of time as a leader, not just in North Carolina, but also in Missouri's Medicaid program. Spent time on the payer side of the house. So you've got a perspective that kind of covers a large part of the ecosystem, and also having been in other Medicaid organizations. When you think about some of the work that you've done there, some incredible work there, being a leader with your Healthy Opportunities Initiative, the health-related social needs work being a model of success for many across the nation. Can you share with us some of your experiences with collaboration in North Carolina?
Yeah, thank you, Jeremy. And it is always good to hear what Jason's doing. We follow the work very closely, and it is an understatement how much effort it will take to do the initiatives that he's doing, as well as the work that we did here in North Carolina to stand up the Healthy Opportunities pilots. So similar to Washington, we are operating under what's called the 1115 waiver. It's a specific authority that allows us to do innovations, and we have applied that innovation really to meet one of our core priorities in the North Carolina Medicaid program, and that is to focus, of course, on whole person care, but to buy health, not to buy health care. And once you start to reframe both buying health and whole person care, and start to think about what that really means, it is not hard to quickly identify needs that are within the span of control, that the causes or the solutions that live within another part of the health ecosystem. And so for us, it has been about developing a framework to deliver on the social needs that communities across North Carolina have. And we do that in a way that is incredibly focused on what is it that the community themselves need. They call it stakeholder engagement, but it's a little bit more than that. It is really figuring out ways to not only understand what those community needs, but then to also empower them with capacity building funding to begin to address those needs. We, of course, work on a population health platform that we utilize here in North Carolina. But then we have a delegated care management model within community, and you're going to hear this theme about community, that we use that population health model. We have delegated care managers in the field who work with and coordinate with Medicaid Managed Care organizations. And then they all identify the need through our social risk screening, and then deliver services through a network of community-based organizations. We have had incredible success again around this model, and I think it's because by connecting community to care managers, to health plans, to the Medicaid program, we're able to build trust with people, the people who need assistance, and that gives them the opportunity to listen. If you're feeding somebody, that is going to be their prime. If food insecurity is going to be their prime worry, housing insecurity is going to be their prime worry. So if you're able to figure out using resources that are close to those individuals, physically close, or delivered by messengers or community members that they're familiar with, it's through these tools that you facilitate an improvement of health. And what we've seen in North Carolina is we have seen through this model of delivering food services, housing services, transportation services, in addition to interpersonal violence, wraparound behavioral health services. What we have seen is a decline in ER visits. We have seen a decline in inpatient stay. We have seen an increase in the amount of time that individuals stay in our population health program. And what that's resulting in is that after the costs of the delivery of that social service, that food box, or that legal counseling around what options do people have to potentially hold their landlord accountable or not, or repairing their car. These services, when you factor the cost of those services in addition to the cost of healthcare, we're actually seeing a decline in healthcare costs. $85 per member per month for those people who participate in our program. Anecdotally, we're starting to see a lower acuity level within the communities that have healthy opportunities. And that, of course, has powerful impacts on what you might pay a managed care company to address those costs. So it is hard. I don't want to minimize how hard it is, and we don't have a 1,000-point spreadsheet. We have 1,000 relationships that we need to coordinate and develop as a system so that they all see themselves working together. But the benefit is not only improved health outcomes, but it's also saving the state money.
Jay, I think it's again, incredible work, and particular interest is not just that you thought out this these strategies, but that when you operationalize them, you were able to kind of see it through to the finish line, and also look at the impact and quantify the results, right? And so congratulations on the great work you're doing there. As we move to you, Karen, and I want to give just a kind of a quick background on yourself and the journey that you've taken. So, I mean, you, just like everybody on the panel, very unique journey, and coming from your early days at a massive federal government contractor, probably better known for its work in the military with Lockheed Martin, to landing at CMS during the early days of the Affordable Care Act, becoming a senior leader at CMS and then having returned more recently to the private sector again, you've got incredible perspective, and you've seen a lot. You've been a part of so many initiatives, and still connected very tightly to many of them. But one of the things I just want to bring up, because it was something that we talked about, was, and as I listened to Jay and Jason and others in this, in this spaces, are we doing things for ourselves or for the greater good and the folks who most need our help? And I think that was something that really struck me from our conversation prior to the webinar. And so as you look back at your journey, Karen, and your continued efforts, can you share some of your experiences as well?
Yeah, absolutely. And thank you for that. I want to congratulate again Jason and Jay for the work that they've done, because I want to pay respect to how hard this is. And this is not just a technological challenge, it's a relationship challenge. A lot of the things that Jason and Jay are talking about required them and the leaders in their state to make a decision to cross streams with another program. And a lot of that requires us to get out of a comfort zone. And there's a lot of us who are serving both private and public in the healthcare space that would say, that would probably push back on the fact that the job that you're doing is comfortable. But there is a place where we live where we are used to knowing our data. We're used to being accountable for our data. We're used to being accountable for the systems that we grew up being good at administering. And when you have to create a cross mapping of those, it's an uncomfortable space for us as humans. And I am testifying to that as a person. During COVID, I was working as the operations lead for Medicaid and CHIP at CMS. And we found ourselves with a bunch of question marks like cartoon characters over our head, trying to figure out why COVID was hitting these different populations in a different way, especially American natives, Alaskan natives, people of color. And we didn't have race and ethnicity data within our Medicaid data set. And so I and those leaders within the organization had to first figure out how to have a relationship with the agencies who had the data that we needed to cross match in order to create a view to the people who we were trying to take care of. And so what you're referring to is the conversation that we had where I said I had to relieve myself from prioritizing the things that I thought I was responsible for taking care of, which was the Medicaid ecosystem and the Medicaid data. And when I had conversations with the census agency, they kind of met us at that same place where we have these regs, we have these rules, we have these things, we have these first priorities that we need to consider. And so we both had to access our higher angels to get to the urgency of the public health emergency, to realize that it was critical for us to get where we needed to be, to figure out not all of the reasons why we couldn't, but some of the reasons why it was just really important and failure wasn't an option. And so we got to a place where we were able to collapse that data and use a combination of that data to create very accurate and real-time reports on who was affected, how, and where. So we are still on a journey as a country to find out all of the cultural and clinical and social differences that create those disparities. But I think the key is you can't manage it unless you know it. And so all of the work that we do as humans to have what I call the CCB, which is first you have a conversation with someone who has a unit that you need to access, such as, housing, justice involved, all of these places, these prison systems, like folks talked about before, that are not used to engaging with Medicaid, not used to engaging in the healthcare system, and start to break down those levels of discomfort that we have on both sides with having a conversation. And that leads us to the next step in my experience, which is collaborating. You actually have a conversation about the how and all of the things that you can do to collapse those lanes. And then the third thing is just a brainstorm, right? Because I figure if you get to once you get past that relationship piece and there's a conversation and you start to have a collaborative group or you start to meet on a regular basis, that releases all of that innovation energy, because you start to you start to stop focusing on all the why nots and you start to create the why we can. Another good example of how that happened was a lot of the collaboration that happened internally inside of CMS during the Medicaid redetermination effort, when we all had to figure out a solution for how we catch people who were being terminated from Medicaid and make sure that there was an opportunity for them to at least assess applicability for the ACA and the healthcare exchanges. Those systems exist within one federal agency, but they weren't exactly pointing towards each other. So the conversation had to start first, and then the collaboration, and then the brainstorming, and that's how you get to a solution. So I feel like all data doesn't desire to be disparate. It doesn't desire to be different or set apart. It's the humans who have oversight and responsibility for that data that probably have to figure out a way to bring their higher angels to make that data actually start talking to each other. And like you've heard these two leaders in these great states talk about, once you make that decision, the rest is a push towards the patient, towards the beneficiary, towards the human in the center who actually needs for us to get there and accelerate that.
Yeah, I think that kind of an excellent kind of breakdown of the process as you've seen it and experienced it, and both at some of the largest kind of challenging and most challenging times in CMS history, right? From the that approach that you took during the early days of the ACA and the problems we have the exchanges up front and to the flood of new beneficiaries coming in, to what you just described during the pandemic and post-pandemic, right? And it's never going to be perfect, but the lessons to be learned. And I think there's still a lot of challenges as we go through this journey, especially with regards to how we get to that finish line, like you were just mentioning. And a lot of these things start with ideas and with policy and programs and everything we've just heard from the great folks in the state of Washington, North Carolina, and from your experience, Karen. And I mentioned that finish line and that getting to the last mile. And I think that kind of tees up very nicely for you, Abner. You've had also an incredible journey like everybody else on this panel, and you've worked as a champion for decades. For folks who are underserved and looking at ways in which we can mitigate health disparities across the U.S. and abroad. I think incredible work. In 2017, you founded Same Sky Health, an incredible organization which was focused on better ways in which we could assist the underserved communities and more actively, or more effectively activating people into care, really in the way in which Karen just described, right? I think a lot of folks just assume that folks understand how to activate into care as a Medicaid beneficiary, and we all know that is not the case. It's a challenging set of hurdles to navigate. So as you went through that journey, Abner, you've obviously in recent time you have found yourself part of a merger with the Ground Game Health organization, and your hyper focus on looking at ways in which you can better serve these marginalized populations and reduce health disparities is still very much on the forefront of what you're doing at Ground Game Health. Can you share some of your experiences in terms of collaboration, and how do we get across the finish line? How do we get that last mile addressed?
Sure. Thanks, Jeremy. And it's great to be here with the other panelists. I loved your comments, Karen, and I just want to echo your congratulations to Jason and to Jay for the incredible work they're doing. Side note, I'm from North Carolina. I'm from Durham, Jay. So I take special pride in the work that's happening in North Carolina. But I think it is the exception, not the rule. So maybe I'll just comment initially on what I see as the real as a continuing challenge. We know that we have the situation in our country where sort of medical and clinical care has been siloed from social care. We increasingly now know that we're not going to achieve our clinical goals and our medical health goals for people if we don't address their social concerns. But just to be very practical, we are a country that has been very willing to spend enormous amounts of money, for example, on diabetes treatment, but we are reluctant to spend $1 to get healthy food to that person, even though we know that the food they eat is gonna significantly impact their diabetes and may actually undo all of the clinical work if they don't have the right food. We are a country that historically has been more willing to spend on the medical side, and we're kind of stingy on the social side. There's a lot of history, reasons for that, but I think what's exciting now is that that as a country we're coming to understand we've got to get beyond those two silos, that the health, the clinical side and the social side. We've got to build connections between them, because we're never going to achieve the health goals we have for people if we don't address their social needs. And that diabetes example is just one, and Jay mentioned some others. So that's the really good news, that we've reached a point where we are saying, okay, we've got to get out of the silos, we've got to connect. But I think that there are two cautions we have to have as we move forward in trying to bridge that gap. The one is that we don't want to clinicalize social care. Medical care and healthcare providers, they should focus on what they do. We have community-based organizations all across this country, in every community. They are made up of people who have dedicated their lives, their careers and their lives, to solving social need. They are embedded in the communities where they are. I think, Jay, you mentioned this, they're trusted. They're geographically located in the right place. They're trusted. They know what they're doing. We ought to figure out a way to use those, to partner with those community-based groups and have them be part of, and I think the lead part of how we solve social need. And I hear that's what's happening in Washington and it's happening in North Carolina, but I just want to, I think, be transparent. What we're finding at Ground Game Health, and we serve, we're working in about 25 states across the country. We are trying to help community-based groups to partner with healthcare stakeholders, primarily health plans, payers, but MCOs, but also other healthcare stakeholders like health systems and providers. What we're finding increasingly is that community-based organizations continue to struggle to contract with, to partner with healthcare, with managed care organizations. It's not fair to the community-based groups for us to recognize that we need to empower and engage these community-based groups. We need to, for instance, when we have a member, a Medicaid member who's hungry, who has food insecurity, we know that local food pantry or that feeding organization or the organization that's going to get them signed up for a program like SNAP or WIC or something, we know that's the best place to send that member, particularly if they need food tonight. If they need food tonight, the best place to send them is a local community-based organization that has food that they can give them tonight. The problem is we can't just do those referrals and not provide the funding. We can't just say to the community-based group, here's a whole lot of new folks for you to serve, but there's no money to help you meet those needs. We've got to make it sustainable, to make this smart idea of including these community-based groups sustainable. We got to provide the funding, and that means we've got to have contracts between the community-based groups and the healthcare stakeholders, and the community-based groups are really struggling to contract with the health plans. It is the exception, not the rule, that they're able to do it in the U.S. today. And a lot of the healthcare stakeholders, and we talk to a lot of health plans, they're struggling to connect and build with a network of community-based groups. They don't speak the same language. For example, if you have a local food pantry, this is an example, for that local food pantry to be high trust certified, impossible. For them to have the insurances that are typically required to have a contract with the managed care plan, not going to happen. For them to actually do claims work, to have a revenue cycle management and do claims so that they can actually bill the health plan, it's a heavy lift for a local food pantry, even though that's the best place to provide that health plan member with food. So the point I'm trying to make is we have to take the perspective of the community-based groups into account here, and we've got to build pipes that allow for a seamless integration. And here's the important part, that doesn't require the community-based organization to become something different than they are in order to engage with healthcare. We can't say to people, you got to be different. You got to become a healthcare type organization in order to engage with healthcare. That's not going to work. It's not sustainable. We're trying to be part of that solution at Ground Game Health. But when I'll give you one example. I was at a recent conference for U.S. Aging, a fantastic organization, their national conference. I was on a panel. I actually asked the folks, these are folks attending who represent area agencies on aging, one of a very established, rooted community-based organization helping seniors. I said, raise your hand if you have a contract with an MCO. And not one hand went up. And so, and this was recent. So my point is, we've got a long way to go. And that's not the exception. As I said, that's the rule. So the first point I want to make, and I'll stop here, is that we've got to do a much better job. I think North Carolina and Washington are leading the way here. They're good examples. California has a program called CalAIM that we're trying to do the same thing in California. But we are a long way from building the pipes, the connections that we need to make this really work.
Abner, thanks so much. Couldn't agree more. And I think it's an excellent tee up, by the way, for where we're going to go next on our journey here. Before we do that, and Abner will be first, we have one of those quick poll questions. So we're going to take about 45 seconds here to answer this poll, and then we'll continue the webinar. Right, perfect. Well, thanks for everybody that was able to participate in the poll. We're gonna keep moving on here. We'll have some live results from that poll when it comes back. The Abner, I think you teed it up very nicely for how, and there we go. We've got some great live results here. Thanks, folks should be able to see this. But again, we'd love to see that needle move, by the way, from this area where everybody is kind of in this limited and good area up to the excellent. Gonna take some time, right? And I think that's what we're hearing here. So thank you everybody for participating. It's fantastic to see these results. It'll help us to again continue to push policy efforts and program efforts in the right direction. Abner, continuing this conversation, and again, you've got a tremendous amount of experience in this particular area. You mentioned a bunch of the challenges, right? We were talking about organizations that are not traditionally set up to be nearly as technically mature as big payers or providers or traditional kind of healthcare organizations. They struggle with this aspect, and we have to make this approach, this strategy, a lot more streamlined and interoperable. We got to make it in a way in which I think everybody can kind of play nice in the sandbox, right? And we've struggled to do that, as you very much firsthand. Can you talk about your experiences with data analytics and how? And again, you alerted to some of that already. Whether it's looking at ways in which I know that you all are looking at ways in which you can identify the at-risk populations, or identifying particular needs for community-based organizations, how you match up folks to those right organizations. I'm just probably scraping the surface. Why don't I hand it to you to talk about your experience?
Sure. So I'll just mention two things. One is we found, and we're doing this work at Same Sky Health, and then when we merged with Ground Game Health, we continue to do it. We have, and this is a frustration when we were at Same Sky Health, we built a technology platform that allowed us to create really personalized, customized engagement journeys for people. So health plans would hire us. The health plan would say, we've got a lot of members that we don't have a good relationship with. Some of them, for instance, they haven't come in for a wellness visit in 4 years. We struggle to connect with them. And part of the reason was that they had a sort of one-size-fits-all approach to their engagement. So what we focused on at Same Sky was creating customized sort of N-of-1 engagement. We used data, public data, private data, claims data, as well as a lot of deep understanding of how different communities engage in healthcare, different levels of trust for healthcare. We created sort of culturally sensitive, but we define culture more widely than just skin color or country of background. It means, if you're rural versus urban, if you're comfortable with technology versus not comfortable with technology. So the idea was to use data and interactions to understand who people were at that deeper cultural level. We would engage folks. We would ask them how they wanted to engage. They much preferred text messaging, for example, is a key learning, to US mail or even email or phone calls. They much preferred, this is true across every demographic and every income ladder, but certainly folks in Medicaid preferred text messaging. So we started to treat people like who they are mattered. We got away from the one-size-fits-all approach. We engaged them in an N of one. We used technology to do this. You can't do this without technology. And we were able to build enough trust that people would share with us what was happening in their lives. And they would tell us things like, the reason I'm not bringing my child in for a well child visit is because I don't have rent this month, and I got 2 days to pay rent, or I'm going to be out on the street, and I don't have the money. And so we really struggled at Same Sky because we didn't have a solution for that. And that's why we love that we have merged with Ground Game, because Ground Game works with community-based groups. So now we have a local resource. We have folks that we can connect that member to. We built trust. We use data to build trust. And that's a strange thing to say, that's data to build trust, but it really was data that allows us to create that customized N of one, who you are matters kind of engagement that built trust, that allowed people to tell us what their needs were. And now with the merger with Ground Game, we're able to connect them with community-based groups who can meet that need. So I'm excited about what we're doing, but the challenge is twofold. One is it's not happening enough, and community-based groups are still struggling to connect with payers and providers and and other healthcare stakeholders. And as the poll just showed, I suspect most of the people on this webinar are more from the payer and health stakeholder side. They're all saying they don't have great networks, they don't have great collaborations, and so we need to figure that piece out. The other thing I'll say quickly is, one thing that we are also missing is and I think it's really important for us to develop this, is a social record. We've spent a long time having an electronic health record, right? But we don't have a social record. And think about that person who is the patient or the member that is going through challenges around social need. The fact that we aren't collecting that data, obviously in a HIPAA compliant and high trust way, but we should collect that data just like we do their clinical data. That should help inform decision-making, both on the social and the clinical side. Today in America, there are very few places that have a social record. It's one of the things I think we really need. It's like the next step in data analytics, because you really can't understand who that person is if all you have is their health record. Because their social, what we know is the social side is actually more important to their future and how we're going to engage with them and how they're going to improve their lives than even the clinical side. And we don't have that social record. We have the ability to do it. We got the technology to do it, but we aren't doing it. And so I think I just want to put that out there, that that's a real need that we have, and we need to get our act together and fill it.
I appreciate it, Abner. I think you're spot on. And we can never I don't think we'll ever be able to put into words how important that social record is. And, again, in our experience here in Innovation, we've been seeing a lot of traction. We've been helping out with organizations that are looking to create these community health records, social health records that span across social and the clinical side of things. And we're kind of early in that journey, but I'm really excited to see the results of those and other projects. And, as we move to you, Karen, and your experience, obviously the role of data, you mentioned it, right? The race ethnicity data that is missing still from many records in the COVID space. I think I looked at the latest, and there's still a very high proportion of data that's missing. I know that there's a tremendous amount of data that is missing in most EHR systems that surrounds gender identity, a very big problem. From your perspective and your experience, how do we move the needle there? And what are your experiences, Karen, with the incredible importance of data and analytics as we, continue down this journey?
Yeah. So there's I am a firm believer in engaging both the person receiving the services and the person delivering the services, and some of this accountability. And the reason why I include the person receiving the services, because I believe there is great power in a person who has a provider and asking them all of the things, right? Do you have access to my dental information? Do you have access to my health information from the doctor that I went to last week? Can I have access to that information? How soon can I get my test results and my electronic health record? That's one part of it. And I believe that piece of agency, I'm often asked when I have conversations, especially in audiences with people of color, what do I believe are some of the great accelerators that will put us to a place where we have, especially for people of color and minorities, an increased focus and ability to manage our health and to have more attention paid to the things that culturally impact us, et cetera. And I believe, and the thing that I always answer is health agency, right? And so it's not just health information, which I believe is very critically important, especially for everyone who is involved in the care circle, but agency, meaning, historically, how we have held our providers in such a level of high esteem that we don't pull that data from them. We don't ask those questions. We don't encourage them to provide us with that information. And we don't create an environment where they believe they owe it to us. And then we don't actively engage in it. So there are all kinds of places in our community where that is not possible, and that a caregiver should be able to support that. But I want to just I want to take some time to focus on the fact that there's a top down and a bottom up answer to this, right? And I think the reason why I need to say that is because this does not get done by one place in our ecosystem. And there will be different times throughout the next phase of the progression in healthcare, wherever it's going to go, where it will be heavy on one side, it'll be heavy on regulations, it'll be heavy on, delivery. As Abner talked about, there'll be gaps in places where the delivery at qualified health centers and CBOs, where they actually see what is happening, that gap isn't filled. But I think the key is, again, if we continue to communicate about those gaps, continue to hear from the people who are actually touching the humans, and continue to be humans who require this of everybody who touches us, engages with us, or has any accountability for our well-being, then I think that starts to get closer to the center of where we're trying to be. What I have always been proud of, especially in my federal service, is the first of all, I am a big fan of the federal state partnership between the government and Medicaid, because I believe those checks and balances make sense. And those checks and balances are what we need in order to deliver. And I feel like, even though I know there's tension built in, we keep each other honest, right? And so as we get to a place where you have, and especially when I was at CMS, when you had multiple states that were telling you the same thing about the way their citizens were receiving or impacting, or what their needs were, you put yourself in the position to prioritize change at the federal level. And it takes a long time. I know it takes a long time, first of all, to get it passed. It takes a long time to get it explained. It takes a long time to get it implemented. But all of that, in my experience, is done with respect for the ecosystem that you're changing. Because even though we need to see things happen sooner, faster, and better, there's 50 states and 10 territories and a whole lot of people and a whole lot of systems that are impacted that you have to have respect for. And so I am a big fan of what I call operational empathy, which means that you ask questions about the people and the systems that you're going to touch to see, I'm about to make this change. How is it going to impact the way that you are currently delivering services? And so when you have data that informs those conversations, it puts you in a position to, first of all, baseline where you are right now, and then very effectively monitor how the ecosystem changes as a result of every new thing that you touch. And so I just want to I guess what I'm offering is a little bit of an apology for the speed of change that is not happening. There is a level of change that we can accept as a unit that is responsible for healthcare. I think that either is you go fast and you fix it if you broke it, or you take your time and roll it out and try first to do no harm. What I'm excited about are all of the things that have happened. I mean, meaningful use, from HIPAA to meaningful use to interoperability to uniform data systems to FHIR, all of those things are, in my opinion, aggressive national drives towards the center of the universe that we are all trying to create, where we know more about each other and we know more about how we impact each other, so that those of us who are put in a position to create a prevention system have more strategic information. I think one of the biggest things that concerns me about our ability to tackle healthcare in a positive way is how reactive we are. I think we all feel that, how reactive we are. And the best thing about leveraging data analytics is it puts us in a position to be more strategic, and we owe each other that.
Good, Karen, excellent points. And what I'm hearing from that is a lot of what we have in the background, by the way, so folks, you see we've taken the time to put some points on here. But the one that sticks out to me is I have this analytics for all. Let's find a way to enable everybody to be some level of an analyst, because data is a part of us. It is a currency for all of us, right? And the more we can get folks to better understand and have a voice in when what data is captured, how it's used, and same thing on the analytics, I think we're going to see a tremendous amount of upside. So thank you, Karen. And Jay, if we shift over to North Carolina, I'm going to kind of pose a natural progression of the same question and ask, when you think about data and analytics and some of the work you're doing there, obviously it's played a tremendous role. I'm very familiar with a lot of the work that you've done on the data analytics side, but you also are bringing in AI into the mix. So do you want to speak around data analytics, the role of AI in your efforts?
Yeah, absolutely. And really good points I've heard, and some things that I've learned today as well. When it comes to data analytics, there are data analytics on probably both sides of the coin. One is in identifying the need and whether it's the individual's need for support, what would make them healthy, what would give them health, as well as what is missing in the ecosystem around who would deliver on this need. And I think that there's a whole role of analytics and working with different divisions and departments within state government to help identify, commerce. Sometimes you need to develop new industries or businesses, but that again takes time. And then the other side of the data analytics is, what is the ROI? It's probably one of the most common questions I get, and in some ways it's a little depressing. But of course, we need to understand, what is the return on investment? What is other than making somebody healthy, other than giving them a stable source of food and a stable home to live in, security. Other than that, what is the ROI, Jay? And that's a question that I get more often than I want. And so data analytics really plays into that. And what makes this space different, North Carolina's social determinant space different, is that we are developing something new. And so that measuring that ROI requires data analytics in a way that arguably doesn't exist yet, or you're trying to pioneer it. Because what is the ROI of I was able to tell you $85 PMPM. That's really concrete, and that comes from data analytics. But how do you connect that with the value of a child being able to stay in school, or a parent being able to go to work routinely because their child is staying at school, right? How do you measure that? And so there's a lot of analytics. I think AI for us is probably trying to assist population health or care managers in identifying what is the potential need, the unspoken need that's hidden in the data. I think that it helps us, again, continue to identify what those missing services might be. What is the little thing that would improve or increase the the reduction, I said increase, and now I'm going to reduce it, but reduce the number of ER visits, continue to reduce those ER visits and those inpatient stays. So it's really, how do you combine all of these different data sets and make them rational and accessible to population health care managers?
No, thanks, Jay. I can agree more. So as you continue the journey, we're going to be excited to see how your efforts shape out. And I think, over in Washington, Jason, just think about the same question. Your experience, you got a lot going on with AI. I know in Washington, and data analytics has been a big part of your efforts to date. Do you want to speak about your experience there?
Sure, Jeremy. If you don't mind, maybe I'll start too with the question that's in the Q&A about how we're engaging really customers and people as opposed to organizational demands. And of course, that's a high bar in the sense of legislature may have requirements, the federal government may have requirements. So clearly, we have to follow those legal and our authorizing environment requirements. But we have to do it in a way that's always customer driven and patient focused. And in Washington, we've reorganized. We call it the customer experience and trying to improve that. We've looked at our eligibility systems and trying to integrate across systems. So to Abner's points, social and healthcare eligibility programs and systems. We also reorganized to really focus on our work in that regard. We work with people with lived experience, and we pay them for their time to participate in our activities and our advisory boards and so forth. I want to give a sort of a special government to government sovereign nation respect to our American Indian, Alaskan Native, and our tribal populations and our 29 federally recognized tribes in Washington state, which is an incredible I find it an honor working with our various nations and governments in that regard. And it is so rich in terms of improvement opportunities for us all in healthcare, particularly. Talking about data needs, in Washington, we've got a few things that I think cross from Abner and then Jeremy to AI. We have what is in essence our healthcare system that we can centrally purchase and license out to help providers, typically non-traditional providers or smaller providers, really have a health record. And then that we can help pay for and subsidize through some of our waiver capacity dollars and some of the legislative funding we have. In addition, we are building out what is basically a social health record and a referral source called our Community Information Exchange. So we are building that out. In addition, as I mentioned, thinking about how we can build out eligibility systems to make it easier. The Affordable Care Act brought great improvements for Medicaid eligibility through 24/7, 365 online eligibility and click the box and get the information out, but not so much for some of the other social programs, and not so much for our classic Medicaid population. Age blind, disabled still has to go through a fairly manual eligibility process. So how can we update all of that? I think with regard to AI, thinking from a Medicaid, government, and healthcare dynamic, that's where we're at, right? We need to lead on AI ethics. Period. And what that means is we have to do a heck of a lot better job getting up to speed on where we're at with AI as a government, first of all, and certainly as a Medicaid program. What can we do to increase representation and decrease bias by having underrepresented communities represented in our models? How can we ensure models are the right models and the right prompts to reduce those risks of bias in the first place? How can we use the data from the CIE, the eligibility programs to ensure social determinants of health, health-related social needs services are connected to healthcare? and thinking about what our oversight role is for our contractors. And so our managed care plans, our national leaders, and all really, quite frankly, leaders in using AI today. And I have met with them all, and presentations show that they are ethical leaders in that regard. But we've got to ensure that continues, and we have to have a much better understanding of how to work together to continue, and these improvements will be generational and changing for our entire society.
Jason, thank you so much. I know we're coming up on the last 5 minutes here, so we're gonna kind of make a bit of a not a game show reference, but we'll do a lightning round to kind of sum things up, and I would ask for the panel maybe in 45 seconds or less to give us your thoughts on the future. And Jason, you're first, so it's the baton is in your hands, and you know, what are your thoughts for the future of cross collaboration efforts in Medicaid?
You know, I think it is going to be hard work for government bureaucracy to move in that right direction. But I think, as we heard through our comments and discussions today, we're on the right track. And I'm happy with where we're heading in Washington. We have such incredible challenges ahead, and we cannot lose sight of that. And we have to continue working. We have to focus on people with lived experience, our customers, our patients, and the people we serve. And that has got to be the first thing we think about, to the extent that we can, with our other instructions from legislature and federal government and others. So incredibly challenging, but and if we can use data, and if our data systems and our IT systems and our AI, it's a bit of a tail wagging the dog here, folks. These are so expensive. These are costly. They require a lot of resources. And, you know, I think to Jay's point is what's the ROI? And what's the ROI in the sense of not just the dollar, but to improve care and services for the people we serve? And I think too often we're not looking at that as well as we need to.
Thanks, Jason. Jay, you're on the clock.
All right. I appreciate, what Jason is saying. I do think that there are as long as we remain focused on people, I feels, I don't know if you've heard it, there's been this undercurrent of empathy, humanity, right? An acknowledgement and recognition that the lives of people that we serve are complex, that there are struggles and opportunities that, we can't fathom, but it's our responsibility to either get out of their way so that they can live their own life, or enable them and support them in the way that they need support. And that's defined by them. I think that that's defined in a whole person care model. It's defined by the person. We're working on a number of programs around whole family, and that is similar, and then whole community. And I think that the more that we're able to support and enable community to develop the resiliency and strengths it needs in order to support the families within that community, I think that we will see a progression towards a healthier individual. Now, I'm not Pollyannish. I think this is going to be really hard. Healthcare is increasingly political. So as we draw some of this in, it's going to get even more political than it already is. It already is hard to feed people. That's political for some reason. And so I think that there is a complexity, but I do think that by remaining focused on the individual, family unit, as well as community, I think we're going to be headed down the right path.
Excellent. Thank you, Jay. Karen?
Yep, I'll just be short. I will tell you that what I believe is that there's an opportunity for each of us as an individual to do a couple of things. Request and require, like push and pull for if you are a person receiving services, request and require that the people giving you those services move towards a more data-enabled environment to serve you. The other thing is if you're a leader or someone who either serves the public or serves the bureaucracy, push your team, push your agency, push all of your constituents to just lean further towards the middle. It actually makes a really huge difference, as you can say, by all of the amazing work that Abner and Jay and Jason have done. So I believe like that individual power exponentially activated will be our answer.
Excellent. Thanks, Karen. And Abner, you were on the clock last.
Sure. So I'll just say it's really important as we get deeper into this effort to address and solve social need that we not confuse efforts with results. Efforts are necessary, but not sufficient. When people need food or housing, or they've got a domestic violence situation, or they don't have money to pay the rent at the end of the month, efforts aren't enough. And we run the risk of checking the box by saying, I sent them a link to a service. That's not closing the loop. That's not getting it done. So getting it done is getting food in someone's stomach who needs food in their stomach, or getting shelter for someone who actually, is either homeless or in danger of being homeless. So it's really important for us not to confuse efforts with results. I know this group isn't, but sometimes when you're checking the regulatory box, or you're saying, I did it, I sent them a link, that's not enough.
I couldn't agree with you more, Abner. Thank you so much for your thoughts. And with that, I want to thank the entire panel for your time today, and the audience for your time today. We just got just a couple of wrap-up items here. I know that there's a couple of questions that we didn't get to today, but we will be sure to get those answers out after the webinar. So we'll work on those. And let me just go back here. I think, with that, obviously we see the feedback form popping up as well. It's a lot of different things. We've got a QR code here to look at ways in which you can connect with us. You get the feedback form coming up here, and I'll just wrap up with these thoughts here. Look, I mean, I think, excellent conversation today from some incredible champions in this space. Jay, Jason, Karen, Abner. I can't say enough about the incredible work that you're doing out there. And there's a lot to be learned from this. What I'm hearing from this is there's incredible effort. There's incredible work that's being done out there. There's a lot of love and care and respect for folks in the Medicaid system, in ways in which we can get them to better engage and activate into care, in ways in which they are not today. And I think we had to look to new policy efforts and program efforts into the future, and how we can thoughtfully design those with a lot of the points which we made today in mind. And I would say, hey, collaboration cannot be done in a vacuum, right? It requires strong commitment from a variety of representative stakeholders that you've heard today, whether it be from the policy side, the program side, the provider, payer, community-based organizations, and beneficiaries themselves. They shouldn't just be be recipients of everything like the fire hose is on. They should also be an active voice in this process. And lastly, I'd mention that data, analytics, and AI can certainly act as a strong connective tissue for collaboration and helping to improve health equity and outcomes. But it must be done so with a hyper focus on governance, responsibility, ethics, privacy, security, interoperability, and accessibility. And I think if we keep those values in mind, we will find that data and analytics and AI will provide a tremendous value and a very responsible and ethical approach. So with that, again, thank you so much for staying a few minutes after. And just lastly, I do want to mention with Jay joining us from North Carolina, and for folks who are familiar or not familiar, North Carolina is continuing to work through the challenges in the wake of Hurricane Helene, and a tremendous amount of work that's needed in the western part of the state. So certainly encourage folks to take a look at their a variety of different organizations out there that are helping, charitable organizations, other organizations. So certainly encourage folks, if they can, to do what they can to help. And Jay, certainly our thoughts and prayers are with you in the western part of the state and the rest of North Carolina. So With that, again, we thank you very much for joining us today. And for folks who will be at the National Association of Medicaid Directors Conference, we also hope to see you there. So with that, thank you again to the panel, and goodbye.